I'll request Dr. Sunita Dubey to present her talk on managing glaucoma in uveitis. Dr. Sunita Dubey ka.
Thank you, Manisha, for the opportunity. Actually, some other session is going on in Hall 6, and I'm the moderator for that session, so I'll just finish it off and go. So my topic for today is management of glaucoma in uveitis. So as we know, uveitic glaucoma is a complex disease that often requires a multidisciplinary approach, and control of inflammation in uveitis is vital for management of glaucoma, as inadequate control of inflammatory process can cause further damage to the TM, exacerbating challenges in IOP control. In patients with uveitic glaucoma, medical therapy alone may not be sufficient to control intraocular pressure, and about 30% of the uveitic eye do require surgical intervention. So as far as pathogenesis and etiology of glaucoma is concerned, glaucoma can be closed angle or open angle. More common causes are pupillary block, peripheral anterior synechiae, and in open angle variety, trabeculitis or damage to trabeculum and endothelium secondary to inflammation. It can be corticosteroid-induced glaucoma also, which is fairly common, or a combined mechanism. So the clinical picture depends on the etiology of uveitis. I will not go in detail. So the management of uveitic glaucoma, as I said, require a multidisciplinary approach. One has to perform a thorough clinical evaluation with uveitic profile tests and ancillary tests like UBM and AIOC2024. So along with anti-glaucoma treatment, anti-inflammatory treatment in the form of corticosteroids, immunosuppressive drugs, and immunomodulatory drugs are also required. However, in 30 to 40% of the patients, you need to perform surgery. So now the timing of surgical intervention is very, very important, and most of the studies recommend a minimum period of quiescence between 30 days to 3 months before performing surgery, and at least minimum 3 months is considered ideal, but one should not operate any case at least before 30 days. Now, which surgery to choose? So there are certain factors which affect the choice of surgery in uveitic glaucoma. So it depends on the status of angle, presence of peripheral anterior synechiae, and status of conjunctiva and history of previous glaucoma surgeries. So it depends whether the angles are open or closed. So if angles are open, you have a plethora of options, and now with minimally invasive glaucoma surgeries, you can perform with open angles. You have the choice of trabeculectomy, glaucoma drainage implants, etc., etc. And if there is synechial closure and iris Bombay type of situation, you have to perform iridectomy, and then you can perform any of these procedures. Since repeat surgeries are quite common in these patients, you can choose to do drainage implant after trab has failed, or you can first do mix and then trab and tube. Perioperative uveitis control is very, very important, and as we know and as we work with our retina specialist, we often get the advice to use either systemic steroids or just continue on topical steroids. So this is the chart which suggests that in anterior and intermediate uveitis, if there is no activity, you can just use frequent topical steroids, and there is no need to start oral steroids. However, oral steroids should be started if there is some activity. In case of pan-uveitis, oral steroids have to be started if the uveitis has been inactive for less than 1 year, and if it is an active uveitis, then you have to even give intravenous steroids. So I'll just discuss 2 short cases. This patient, both eyes uveitic glaucoma, young male. He had healed pars planitis and anterior uveitis on Azuran, and he has a history of ATT, anti-tubercular treatment 5 years back. He was on maximal medical therapy, and IOP was still uncontrolled. So both eyes trapped with mitomycin C were done sequentially. However, over a period of time with recurrent uveitis, he required bleb needling, and now he is controlled on 2 AGMs. So trabeculectomy is considered to be the gold standard for uveitic glaucoma. and they have studies have reported that there is 5-fold increase in the failure of trap if there is significant perioperative inflammation. So that brings us to emphasize on the need for control inflammation. We always use mitomycin C to increase our chances of success, and also since in these patients with uveitis there can be a compromised ciliary body and there are chances of hypotony, so releasable sutures and tight sutures are what is required to prevent hypotony. They say that exacerbated inflammation significantly correlated with surgical failure, and surgical outcomes of uveitic glaucoma may be comparable with that of normal POAG if you have, it's not going forward, yeah, just 1 minute.
Yeah, sure, ma'am.
So, prognostic factors for failure of a trap include previous cataract surgery and granulomatous uveitis. Another patient who was HLA-B27 positive, he had a lot of findings in the anterior segment. There was presence of NVI, nodules, and IOP was uncontrolled, as you can see, and even cataract. So we decided to perform phaco with AGV because tube implants have fairly good success rate up to 94%, and they are useful both in children as well as in adults. Valve implants can prevent hypotony because of the presence of valve, whereas non-valve implants are commonly associated with hypotony. Minimally invasive glaucoma surgery we have limited literature, but we have started doing it now in uveitic and steroid-induced glaucoma. Cyclophotocoagulation is the last resort, and because it can lead to aggravation of inflammation as well as it can lead to hypotony in an already compromised ciliary body, and profound IOP drop can be there. And in a study, with including various diagnoses, the rate of hypotony was much more in uveitic glaucoma with cyclophotocoagulation as compared to other diagnoses. So to conclude, uveitic glaucoma is a complex disease and is often refractory to medical therapy. Trap and tube are conventional surgical therapy. However, you need to control inflammation aggressively. It's a multidisciplinary approach. We work with uveitic specialists for this, and MIGS are now promising treatment, especially in open-angle glaucoma stages. However, more evidence is required. Thank you very much for your kind attention.
Thank you so much, Dr. Sunita, for that wonderful talk. I just wanted to ask you one thing, that when we are dealing with a patient of chronic uveitis, we are always scared for hypotony because of the chronic inflammation, ciliary membranes. But sometimes these patients do present with high intraocular pressure. And so what would be the best option of managing the IOP in a chronic uveitis patient?
Yeah, so in chronic uveitis patients, basically there are in between exacerbations of uveitis, which can lead to blockage of trabecular meshwork, and already there are PAS. Most of the angle is blocked. That leads to high pressures. But at the same time, because of the recurrent episodes of uveitis, there is compromise of the in the ciliary body function, which can lead to leads towards hypotony as the disease advances. So I think we need to be very careful, and that is why if we plan to do surgery in such cases, we need to be sure that we do not do non-valved implants where the chances of hypotony are more, or cyclodestructive procedure.
Right.
So I think these precautions should be taken. Otherwise, these patients should be kept on steroids along with anti-glaucoma medication.
Any questions from the audience? Thank you, ma'am. Thank you so much. Yes, please.
Thanks a lot. Thank you.
Patients having hypotony, they can have membranes or the steroid.
Yes.
Yeah.
That has to be taken care of.
Yes.
With surgery might be required.
Right. We are able to identify them on a UBM. And but here the dilemma was that if these patients are having high intraocular pressure, then you have to strike a balance between a cyclodestructive procedure, better to avoid them in a patient of chronic uveitis who are prone to develop a hypotony. Yeah.
Hypotony is more dangerous
Yes.
than hypertension.
Yes.
Hypertension, ocular hypertension and glaucoma. Yeah. Next is Dr. Manisha Agarwal. She is in the Staff Charity Eye Hospital and is the UVA and Vitreoretina department head. Is a fantastic researcher, and he contributed understanding of tubercular granuloma and a new treatment modality, moxifloxacin and anti-VEGF agents. It's a very good contribution, and we are going to listen to him from her role of diagnostic vitrectomy and ACTAP in uveitis. I thought that these are the very important and relevant topics, but unfortunately we didn't have that much audience.
Thank you, JB sir. And I'll be briefly discussing about the role of diagnostic vitrectomy and ACTAP in uveitis. As far as the ACTAP is concerned, it is always important when we have a diagnostic dilemma. It's a minimally invasive procedure and it's quite safe, which can be easily performed as an outpatient procedure. It helps in diagnosing and excluding malignancy and infection in patients with ocular inflammation. So what are going to be the indications of an ACTAP? It's primarily going to be an infectious keratitis, endophthalmitis, and infectious uveitis. As far as non-infectious is concerned, it can be a non-infectious uveitis, any underlying masquerade where you're not able to identify the cause of inflammation, an atypical response to therapy during the treatment of presumed autoimmune intraocular inflammation, and also to collect a sample for cytochemistry and cytology. So we should not treat that as with a low priority, and it should be taken as any intraocular procedure with an informed consent. Topical anesthesia should be given, aseptic precautions should be taken, and it is best done with a 26 gauge needle loaded on a 1 or a 2 cc syringe, and 0.1 to 0.2 cc specimen should be collected. So this is just telling us how the procedure is to be done. And if you are having the exudates collected in the lower part of the anterior chamber, then it is best that you direct the needle towards those exudates rather than in the serous or the clear aqueous humor, because that is not really going to help us in getting anything on doing a lab investigation. So these are certain things we need to keep in mind. And also, I usually prefer a 2 cc syringe over a 1 cc syringe, because the plunger goes very high for you to be handling it with one hand, and in a 2 cc it is more comfortable to handle the syringe, the plunger of the syringe. Coming to diagnostic vitrectomy indications, it can be planned for an intermediate posterior pan uveitis of unknown or suspected origin where conventional methods such as the clinical assessment and lab investigations have failed to determine the cause. You also can have a strong suspicion of an underlying masquerade, a potentially sight-threatening uveitis with negative labs and ancillary investigations. And when you are dealing with an atypical presentation of uveitis, it is better to resort to a diagnostic vitrectomy. And this slide basically enumerates the various causes where you would actually think of doing a diagnostic vitrectomy, where you are lost in making a diagnosis. So you should aim for collecting an undiluted sample where there is either no infusion or it is collected under air infusion to avoid hypotony. A special word of caution in a case where you are suspecting intraocular lymphoma, where you have to stop the oral steroid 2 weeks prior to sampling. The lab is informed of the sample coming to them. The cut rate is kept as low as 600, and all the vitreous sample with the fluid cassette is collected and sent to the lab. Preferably, the plating is done in the operation theatre for any microbiological sample. We must have a list of differential diagnoses in our mind, a plan by the uveitis expert about what tests are to be done after the sample is collected. We should inform the microbiologist and the pathologist regarding the sample being sent for testing for immediate processing, and also to know exactly how they want the sample to be collected, packed and transported to them so that there is no damage to the sample that has been collected. A preoperative preparation, a written informed consent also is required for a diagnostic vitrectomy, and the patient has to be very clearly counseled that you are doing it for a diagnostic purpose and not for a therapeutic purpose. A high likelihood of not having, even after having done a diagnostic vitrectomy, you may still get negative report, and therefore the patient should be mentally made prepared to even face a negative report. And since it's an interventional diagnostic procedure, the risk of complications is always going to be there. So this is a small video where we are going to be detaching the tubing from between, and we are going to attach this to a 2cc syringe. And then once you activate your cutter, you can collect the sample in this 2cc syringe. The infusion either can be kept closed or you can attach it to an air infusion pump. And as soon as the hypotony starts happening when you are collecting the sample, you can start the air infusion so that it doesn't dilute your vitreous sample. So after you've collected, please close and rotate the needle so that there is no air going inside the syringe. You cap the needle properly. And if you're doing a microbiological sampling, then it is better to get all the culture plates in the operation theatre and do the plating in the operation theatre itself. So these are the various culture medias that you see which are being plated in the operation theatre. And I'm sure JB sir is an expert in this and he will be helping us understand these procedures better. The test that can be done on a vitreous sample, it can be sent for a microbiological examination, for PCR, for histopathology, cytology, and for immunohistochemistry. And these are going to be all tailor-made depending upon what patient you are dealing with. So these are one of the case examples where we have an 18-year-old boy not vaccinated with BCG, diminution of vision for last 6 months. You see there's a kind of a yellowish lesion in the macular area of the left eye. A hyperemic disc is there and an extensive subretinal fluid is also present. I did a fundus fluorescein angiography which just showed a stippled hyperfluorescence in the left eye. The provisional diagnosis that I had in my mind was that either it's a tubercular abscess, any chronic infection such as a fungal infection, a lymphoproliferative disorder. On investigations, the other things were all pretty normal except that the Mantux was 0. I really didn't know what I was dealing with, so we subjected this young child to a diagnostic vitrectomy where the sample was collected over this macular lesion. And it was sent for examination in the lab. Acid fast staining came out to be negative. The PCR for MTB bacilli was also negative. The culture started having this fluffy white growth on chocolate agar, and it came out to be a gram-positive filamentous bacilli, finally diagnosed to be as nocardia species. And MRI brain was done to rule out intracranial nocardiosis in this patient. The patient was treated and he responded well to the treatment. And you find that the fluid has gone, the lesion has regressed, and the patient has recovered a vision of 6/18 N12. This is another patient of Dr. Vishali. I've taken these slides from her. Who had an atypical presentation of a retinochoroiditis lesion. You see the extensive lesion. And the patient had been treated with intravitreal triamcinolone somewhere else, treated with oral corticosteroids and antitubercular therapy for 8 months and not having any response. And the patient finally was subjected to a diagnostic vitrectomy and came out to be a toxoplasma lesion, treated with antitoxoplasma treatment and with intravitreal clindamycin injections, beautifully showed a regression. And when the patient was again asked that, do you have any snaps where you initially presented? These were the snaps which the patient was carrying, which were very typical of a toxoplasma lesion, and the patient had been misdiagnosed to be having a tubercular choroiditis and treated with intravitreal triamcinolone, which had spread the lesion and led to a very atypical presentation. This is another patient, a 60-year-old male patient who was having a history of COVID. He was admitted in the ICU and he was diagnosed to have fungal endogenous endophthalmitis secondary to that. And where you see very classical, picture of sub-RPE deposits which were present in both the eyes. And here again we were a little lost, though it was a very classical presentation, but because he had already undergone a vitrectomy at some other center and being treated for a fungal endoff, this was a repeat subretinal biopsy which was performed by me, where I collected this sample of the subretinal deposit, and this was then subjected to various tests, and this showed that this was in fact a patient of a B-cell lymphoma patient, and the patient was then subsequently evaluated with a PET scan and MRI brain. He was then treated with intravitreal methotrexate injections, and you see this is after 2 injections, after 4, after 13 injections of methotrexate, and this is after 15 injections of methotrexate that the lesion has completely regressed, and the patient still continues to maintain a vision of 6/9 and 6 in this eye. So the take-home message is that whenever in doubt and not able to confirm the diagnosis, or there is a poor or no response to treatment, please do a vitreous sampling in uveitis patients. Preoperative ancillary testing to the best of use like FFA-OCT, ultrasound and UBM should be done before planning any interventional diagnostic procedure. A clear plan by the ophthalmologist is essential, with preparation of the microbiologist and pathologist and list of the tests to be done. And there's absolutely no need to control the inflammation prior to diagnostic vitrectomy. Like I mentioned it in a case of lymphoma, actually if you start the patient on steroids, it can actually damage the lymphoma cells, which you will fail to pick up when you've done a diagnostic vitrectomy. So please keep all these in mind, and this is going to grossly help you in managing your patients rightly. Thank you so much. Any questions? So I'll now invite Dr. Biswas. Dr. Biswas needs no introduction. He is the head of uveitis and ocular pathology at Shankar Nethralaya, Chennai, and he's a teacher for majority of the uvea specialists of our country. He would be speaking to us on the role of injections and implants in uveitis.
I may exceed a little bit.
Sure, sir. You're most welcome to do that.
It's a very important topic, and all the topics were very relevant and important, and I thought that I'll share the injections in uveitis, which has become an important addition in the treatment of uveitis, both infectious and non-infectious. So the route of administration of drugs is the topical, systemic, and then come the periocular, and then intravitreal or intraocular injections. So regional drug delivery indications is that when topical therapy is insufficient, we know that intermediate and posterior uveitis, and then there requires intraocular high concentration of the drug at the site of the disease activity. For example, toxoplasma infection. Avoid systemic effects, like the patient is high diabetic, we need to put the patients on intraocular intravitreal injections in such cases. In uveitic macular edema, topical non-steroidal or steroidal drops has got limited value, where intraocular steroid like implant or injections works wonder. Depot of corticosteroids, if non-compliant of oral steroids in our country, in our setup, it's often required. And then if there is a bilateral disease, and then you are treating with that drug, systemic drug, but one eye is very extensive inflammation, severe inflammation, otherwise a mild inflammation, you want to add injectable preparation in one eye in some situations. So how the local injection consideration? First is that where you want to give, periocular or intraocular. How long you want to the actions to there, months or years. Like fluoroacetonide implant can work for 3 years, or where you clindamycin will work for about a week time, intravitreal clindamycin injection. You need to repeat after that one. Dexamethasone will work for 3 months. So the injection can be subconjunctival, subtenon, orbital floor, which the small limited group of people does that, and nowadays is not that popular. Intravitreal injections and implants has come in a very big way in the treatment of uveitis. So coming to the posterior subtenon injection, many of us are giving it, and the triamcinolone is the drug of choice. It's a readily available, cost effective. You take 2 cc syringe, 27 gauge needle, 0.5 ml you give. Duration of action is 2 to 3 months. Complications, ocular hypertension and cataract, and some patients you can have levator palpebrace. If you inject it, then there can be ptosis, which can be embarrassing to you. This is the posterior subtenon injection. This is a diagrammatic picture. You go vertically and then side-to-side movement and then give the injection in the upper temporal quadrant. It should be given as posteriorly as possible so that you don't see it from anteriorly the injection side. If you don't give anteriorly, the chance of glaucoma is more. And this is a small video. I thought that the general ophthalmologist should be there. What I do cotton tube applicator. I put on the upper temporal quadrant and I count 100 and make the people very comfortable, and none of my patients complain that there is a pain. They say that we didn't realize what time you have given the injection. And this is the way you give vertically and then side-to-side movement. You go posteriorly and push it. These are simple injections, and once you give it and see that somebody giving it, you can see that I stopped at 0.5 ml. And then intravitreal injections has come into that long way, and there are several intravitreal injections is given. It delivers the drug in therapeutic levels at the intended site. Refractory inflammation like cystoid macular edema, where intravitreal triamcinolone or intravitreal implant or biodegradable implant dexamethasone you can give. So triamcinolone coming to that one intravitreal injection, 4 milligram in 0.1 ml, usually administered inferotemporally, duration of action 4 to 6 weeks, may clear more rapidly out of vitrectomized eye than an eye with intact vitreous. So intravitreal triamcinolone is compared with the posterior subtenon injection. So there is a cataract progression in similar in both eyes, but what is very important is the IOP. IOP is more common rise in the intravitreal triamcinolone. This is notorious to cause rise of intraocular pressure rise, and you should be very careful. In a glaucomatous eye, you should not give the intravitreal triamcinolone. I won't give it. Intravitreal clindamycin is a very good treatment option, though we give systemic treatment in many of the patients, but in pregnancy, better safety profile, greater drug ability, macular lesion, macular threatening lesion, optic disc involvement, there is intravitreal clindamycin once a week, 1 milligram 0.5 ml or 0.1 ml at weekly intervals is very useful. One give with 400 microgram of dexamethasone you may or may not give. I usually give it, and nowadays there is a work is going on to get slow release implant of clindamycin. Intravitreal glanzacloprid is a great weapon in case of CMB retinitis. Is that best modality of treatment, and this will be followed by the oral valganciclovir. In acute retinal necrosis, apart from that, along with the intravenous acyclovir injection or intravenous ganciclovir injections, you should give intravitreal ganciclovir because it reaches very high concentration and save the retina. Systemically, therapy contraindicated as in renal insufficiency, 2000 microgram in 0.1 ml. We have given 4000 microgram in 0.1 ml in some cases of AIDS with CMB retinitis. Intravitreal moxifloxacin, pioneering work has been done by Dr. Manisha, and particularly in case of tubercular choroidal granuloma and subretinal abscess and frequent injections. She has compared with the anti-VEGF level and the response to the treatment. Non-resolving tubercular granuloma with persisting XRF, as I mentioned, 500 microgram in 0.1 ml injection. We have got one experience of publishing case of a single case report, intravitreal antivascular endothelial growth factor and moxifloxacin for the treatment of tubercular choroidal granuloma and subretinal abscess. Next comes the intravitreal implant, Retisart, Ojudex, Illuvian, Utic, and Excipia, of which the Ojudex is the cheapest. Other things are very costly. Retisart, we are not using it. A suture surgical implant, you have to do a surgery and put the fluorescein implant is there. Glenn Jaffe proposed it. It used since 2005. Releases 0.6 microgram initially and release vitreous over first month to increase 0.1 0.3 to 0.4 microgram day over 3 months. The drug, 30 months it works, but the drug is not available over here, and it has very notorious complication, is 100% cataract in patients and 40% glaucoma, and this glaucoma is intractable. Most of them require surgery. I asked Glenn Jaffe, he said that he doesn't give that much of glaucoma, but my patients, a lot of patients got a significant loss of vision due to the glaucoma. Fluorescein acetonide uveitis study have given that intravitreal fluorescein acetonide implant 0.5 milligram, and it's decreased the risk of recurrence, less adverse events than the retisar. So we had participated in trial. Manisha, myself, is a co-author for this study. 0.2 microgram per day fluorescein acetonide intravitreal implant in chronic non-infectious posterior uveitis. This was published in Ophthalmology Science 2023. It reduced the uveitis recurrence, increased time to the first recurrence. You know, the uveitic is basically a recurrent disease, but the time gap is increased significantly. Control over macular edema, maintain stable IOP level, expected safety profile, high rate of cataract formation is the only significant complication. Huron trial is the significant milestone in the usage of uveitis treatment, intraocular injections, and this was done by the Karen Loader when he used the two doses, 0.7 milligram dexamethasone and 0.35, 0.7 milligram, that is a 700 microgram, was very effective. It's a biodegradable implant. You inject in the vitreous cavity and it produces, it's almost like 90 to 90% success rate. IOP increased by less than 10% of the cases, and this IOP, even if it's increased, it can be controlled with the drugs only. The biodegradable implant, as I told, approved for non-infectious uveitis, bevel entry into the sclera with a 25 gauge injector system. IOP has may be seen around 4 to 6 weeks after. And this is the Novadur system containing a polyglycan is used, slowly degrades into lactic acid and glycolic acid and disappears. There is a small video, and though the vitreoretinal surgeon nowadays there is a pack, paper pack is removed, and that the intravitreal injector system is taken up, and this has got a tab. His tab is broken, and just pull up the tab, and then you hold it like a pen. Sleeve, you remove it, hold like a pen, and then press over that one. Be careful that you don't put it in the anterior chamber. The slow pellet in that directed towards the optic nerve, and you give into the vitreous cavity. Don't give an aphakic eye, because it can come forward and the anterior chamber migration can occur. There is no need to do the suture. Finishes the injection. And this is a biodegradable implant floating in the eye. It is the rice grain size. We used it 15 patients, and they Uveitis implant non-infectious recalcitrant intermediate uveitis, and we found that the cystoid macular edema rapidly resolves with the sometimes rise of the intraocular pressure a little bit, which can be controlled with the medical treatment. And this is the implant in the vitreous cavity, and is getting slowly degraded. The POINT trial compared the intravitreal triamcinolone Ozurdex and subtenon TA and triamcinolone acetonide. Both the intravitreal injection is greater and faster therapeutic effect compared with the posterior subtenon injection, with modest increase in IOP, no significant difference between the two intravitreal injections. This is the POINT trial, which was published in Ophthalmology 2018. Intravitreal fluorescein acetonide Iluvien is used as intravitreal 0.9 milligram, 19 milligram of fluorescein acetonide, can be saved in selected glaucoma patients. Another implant which has been used in the UK Moorfields group, intravitreal 0.19 milligram of fluoroacetamide implant, and this is the UTIC 0.18 milligram of fluoroacetamide implant, FDA approved in 2018. And then suprachoroidal injection XC-PAL, I don't use it. This drug trial was happened in India also, and used as SCS micro injector. Dose is 4 milligram, 0.1 ml of 0.40 milligram MA suspension. Peachtree trial has evaluated the efficacy and safety of suprachoroidal CLSTA for macular edema secondary to non-infectious uveitis. Majority of the patient didn't require rescue therapy, and 50% cases reduction of cystoid macular edema can occur. MERIT trial is one of the very important trials. One should be remembering it, and it gives the green signal to the dexamethasone intravitreal implant, and it oversees methotrexate and ranibizumab. They compared it and they found that dexamethasone scores quite high in the controlling of the cystoid macular edema. Multicentric uveitis steroid treatment trial found that the 7-year systemic corticosteroid immunosuppressive agents is better than fluoroacetamide implant, though there is a follow-up loss of 30% cases. And I don't go into these details. SAFE study, sirolimus, which is not that very popular now, local formulation of sirolimus in non-infectious intermediate posterior and pan uveitis, and better tolerability, safety profiles than this systemic steroid. It doesn't produce glaucoma. Sakura study is the efficacy and safety of intravitreal sirolimus in non-infectious uveitis and posterior segment. Kwandong is the main author of this paper. In conclusion, intravitreal therapy more effective and improving best-corrected visual acuity and CME, but the risk is associated with the cataract, particularly young people, and glaucoma, which in the dexamethasone implant or Uveitis can be controlled with medication, but fluoroacetamide, particularly retinoid surgery, requires surgery. Newer delivery system being added to the armamentarium of corticosteroid injection. We still need to go some before we tell that these are the well-accepted treatment, because well-designed control studies with long-term follow-up is required to find out the efficacy and safety of the regional corticosteroids. I'd like to thank Manisha to give me the opportunity, and I worked for this paper and the studies. I've gone through it and I could share my knowledge. Thank you. This work is dedicated, my all academic effort is dedicated to life and legacy of Dr. S.S. Badrinath, my mentor.
Thank you, JB sir. I think nobody could have done a better justice to that topic, enumerating all the studies and all what is available in today's time, in the form of an intravitreal injection or implants. I just had one question, sir, that since we have so many implants and intravitreal dexamethasone implant is also there, do you still prefer to give a posterior subtenon tricot in any of your patients?
So posterior subtenon produces 18% glaucoma. 18% case of the glaucoma. I go into the economics of the patient. My first choice is Ojudex, but most of the times in our country setup is not possible. I go to the posterior subtenon injection. It used to work, but we have found that many of the patients, even more than 18% in my imagination, is producing glaucoma.
Right.
So glaucoma is the main problem. If I've got a choice between the two, I'll go for Ojudex implant. Ojudex implant is a sure shot.
Right. Any questions? Okay, we move on to the next talk by Dr. Parthopratim Dutt Majumdar, and he would be telling us about managing cataract in patients of uveitis. Dr. Parthopratim is a senior consultant of uveitis and anterior segment at Shankar Nethralaya, Chennai.
It took a little more time.
Good afternoon, all. First of all, I'd like to convey thanks to Manisha ma'am for including me in this IC. So I'll be talking on managing the cataract in uveitis. Now, if you see here, these 5 cataract cases were operated by a skillful surgeon, and you can see the outcome was not that great. So two most important things you have to remember for the successful outcome in cataract surgery in uveitis are the pre-op and the post-op immunosuppressions, because this defines that how successful your cataract surgery will be. So I'll be sharing some tips with that. Now, one myth we believe that if the eye is quiet for 3 months, then we can go ahead for the surgery. Now let's see 2 scenarios. Will you operate these 2 cases? One 28-year-old male, history of recurrent attack of uveitis in the past, HLA-B27 positive, and last attack of uveitis was 4 months back and not on systemic medication. Similarly, a 61-year-old female, history of recurrent attacks of uveitis due to VKH, and the last attack was 6 months back, not on systemic immunosuppression. So many a time, what mistake we do, we forget that the patient is not on systemic medications, and sometimes the last attack is more than 3 months back, so we feel that we can go ahead and do the cataract surgery. I think that is not wrong in India, because sometimes the patients with uveitis present to us with the complication, like complicated cataracts. So these are the cases you need to start the patient on immunosuppressive and then take them for surgery. Now, 3 important points we need to understand. The one is identify the etiology of uveitis. Like if it is due to Fuchs uveitis, then there is no need of steroid cover. You can directly go for the cataract surgery. If the patient is on toxoplasma, retinochoroiditis, white dot syndrome, they are less likely to develop recurrence. Whereas on the other side, the juvenile idiopathic arthritis, HLA-B27, VKH, idiopathic anterior uveitis, these are high likely to develop recurrences of inflammation after cataract surgery. Now, the second point you have to understand that you have to make sure that whether the patient is on effective immunosuppression and for sufficient amount of time. Now, the number 3 point is very important. These are the 2 important clinical signs you have to look for when you are planning to do a cataract surgery. The number 1 is that extensive posterior synechia. If there is extensive posterior synechia, it is very much likely that the patient will have high risk of post-operative inflammation. And secondly, the second important clinical sign is macular edema, the macular edema usually denotes that severity of the uveitis and greater risk of relapse after the surgery. Now, I'll just share a few tips here. Like when we see this kind of occlusio pupillae, where a fibritic membrane covers the pupil, so one should actually utilize those PI to inject the viscoelastic, so that will elevate the entire iris tissue forward, and then we can actually insert a 26 gauge needle and create an opening with that. The next important is when you see this kind of peripheral anterior synechia, you need to understand that you have to do minimal separation. No need to go inside and extensively separate the peripheral anterior synechia, because sometimes these are notorious and they can cause damage to the Descemet's membrane also. Now, I won't be discussing in details with the management of small pupil. I'm sure all of you know how to do this. One important thing I want to tell you that if there is a large pupillary membrane, it should be incised with the microvitrectomy scissor and should be stripped from the pupillary margin before you start proceeding with the phacoemulsification. Now, just few tips about the bimanual pupil stretching with the Kuglen hook. So you have to remember, if it is a very small dilatation, then only Kuglen hooks works best. So in moderate dilatation cases, better not to use the Kuglen hooks. And second thing, if there is a very shallow AC, then it's better not to use the Kuglen hooks, because sometimes it can cause damage to the corneal endothelium. Now, Grishaber hooks, all of we use. One thing you have to understand, because when you start using Grishaber, especially the newcomers or the new surgeons, because the Grishaber hook sometimes causes the tenting of the iris tissue. So once if a surgeon is not careful while entering the phaco probe, they may cause actually iridodialysis and cause damage to the iris tissue. Now, capsular rhexis we all know, but two things we need to understand in uveitic cataract. If they are small, if the rhexis is small, then it can develop postoperative synechiae with the anterior lens capsule or the rhexis margin, and sometimes it can lead to capsular phimosis also. Now, if the rhexis size is very large and eccentric, then this can happen. You can see here in this picture, a part of the intraocular lens is popping up, and this is rubbing the iris when it is not dilated, and that's how you can see this in schematic graphic, that it can cause inflammation of the iris tissue because it's rubbing the posterior surface of the iris. So one should avoid making a very large or eccentric rhexis in cases with uveitic cataract. Similarly, here is another picture. Though the lens is inside the bag, you can see that because of the very large rhexis, a part of the IOL is popped up and it is rubbing the iris, thereby causing a significant inflammation. Now, sometimes, as we know that we need to remove the cortical material properly because these are highly antigenic, but sometimes it can be very difficult because when you are using Grischerber hook specially, because small particle, maybe small lens matter can be there inside the pupillary area, and the patients with high arcus analis, you can miss here. As you can see here in this blue arrow, there is a swollen actually cortical retained lens fragment which is hiding there and causing significant inflammation. So similarly, you need to understand, and because these materials are often lodged in the posterior chamber, and when after surgery they can cause significant inflammation. There is no alternative to hydrophobic acrylic lens, because you see here one silicon plate IOL was used, and you can see this is an electroscopic photograph which is showing that the inflammatory cell is invading the lens surface and going inside it. So always be careful about choosing your lens. Now, coming to my last segment, that cataract surgery in setting of scleritis, we have reported 38 cases of such cataract. So what we have realized, that if your immunosuppression is proper, sometimes you can go with the scleral incision. Now, why scleral incision? Because sometimes you will have a very thin cornea, peripheral, because of the healed peripheral ulcerative keratitis, and extremely thin cornea, so you may find it difficult to go for the corneal incision. So these are the cases you can actually go for scleral incision even in scleritis patient. So sometimes there will be a lot of, you understand that necrotizing scleritis is most common to develop the cataract, but if you are doing proper job, proper immunosuppressions, you can go ahead and do a good cataract surgery also. For example, this patient we could manage without a patch graft, and the patient is doing well till now. So sometimes because the scleral rigidity is very less, so you need to apply a suture so that you can secure the wound properly in this scleritis cases. Now, 2 slides about the pediatric uveitis. This is a boy, 6-year-old boy. You can see here we have treated the boy with juvenile idiopathic arthritis patient with adalimumab and methotrexate for last 1 year. And after 1 year, we have the boy underwent cataract surgery in both eyes. One eye, the cataract was the intraocular lens was well tolerated, whereas in other eye, the patient did not tolerate, and ultimately we need to explant the intraocular lens. So this is very important lesson we learned, that the differential IOL tolerance in identical disease with similar immunosuppression. 1 year of adalimumab and methotrexate, the same disease, but one eye tolerated the intraocular lens, whereas in other eye we need to explant the intraocular lens. So few things you have to understand, that no rule that fills all the eye. If it is a shallow anterior chamber, there is a severe inflammation. If the patient is having a hypotony and age is less than 4 years, then better to avoid intraocular lens in children. Just last slide, that one thing you have to understand, when in pediatric cataract you do a posterior capsulorhexis and try to do anterior vitrectomy, you have to understand that these are uveitic eye prone to develop significant traction. For example, a patient of intermediate uveitis, you are doing a posterior capsulorhexis and doing anterior vitrectomy, you can actually create significant traction and thereby leading to retinal detachment. So it's always better to take this patient for pars plana vitrectomy if you you feel that there is a vitreous opacity which need to be removed. That's it. So I'll just conclude my presentation here, that as is your pre and post-op immunosuppression, so is your outcome of cataract surgery. Extensive posterior synechiae and macular edema, two important clinical signs you need to evaluate before you take the patient for your surgery. Scleral incision can be used in certain conditions in peripheral ulcerative keratitis and necrotizing scleritis, provided your immunosuppression is proper and appropriate. Large and eccentric rhexis can be a rare cause of posterior inflammation, so don't try to avoid the very large rhexis. And no rule that fits eye in pediatric cataracts, so you have to decide judiciously on putting the IOL in these patients. Thank you.
Thank you, Partho. I think you've given some very important tips during your presentation for planning a cataract surgery in a patient of uveitis, which are always a challenge. I wanted to ask you one thing, that very often we see these patients after the cataract surgery, when they develop a posterior capsular opacification, it's very thick. And even after you have done a YAG cap, it tends to regrow. So what would be your suggestion how to deal with these patients?
I think these are the patients we have started doing. Before we do a YAG cap, we hike up the oral steroid in these patients. We plan that we'll be doing YAG cap, but before that 40 mg oral steroid we hike up. And immediately after the doing the YAG cap, if the patient is not steroid responder, I give a periocular steroid, because just
after the YAG cap.
After the YAG cap. But still, in spite of that, sometimes they developed, and it is very difficult to, because you have to sometimes manage them surgically.
Also, it's a very nice presentation with a lot of schematic diagrams. You really hit some of the salient points. My own impression over the years, like I was doing practice of uveitis 40 years, those eyes in the GIA or children with the pediatric uveitis has been implanted. Many of them has become a disaster in that one. It's my experience. What is the lesson which you wanted to give in such cases?
So we have to be highly selective in putting the IOL.
Yeah, I agree.
The aim of managing juvenile idiopathic arthritis will be to delay the cataract surgery as much as possible. Like 14 years or 15 years. So you can delay the progression of cataract by minimizing the topical steroid and starting the methotrexate early. That is the best option.
I was thinking that whether we can give biologics in this patient and then
even
give
after
the cataract.
biologics that I showed the patient one eye, we need to explant the IOL.
So I had a question. Are there any indications which will be an absolute pointer that these are the eyes where you should not put an IOL?
Yeah, that's what I quoted this from an article. Actually, I forgot to put the reference. So and I realized that the patient where we need to explant the IOL, that has a shallow AC. So shallow AC in GIA, I think contraindication for putting.
So
IOL.
just a thought, would it make sense for us to do a UBM in these eyes and see if there are any ciliary body membrane?
Yeah,
those are the eyes where we should not be possibly thinking of putting an IOL. Just a question.
I think the message should be that for GIA patients, the best is that we don't put in an IOL.
Lens and vitrectomy.
Yes.
Lens and vitrectomy.
Yes,
Safe.
absolutely.
I didn't find any patients losing their vision.
Correct.
Is doing a cataract surgery is much more dangerous than not to do a surgery.
And
Cataract surgeon need to control his ego.
Yeah.
And I think PGI Chandigarh is now coming up with a long-term follow-up of the GIA patients who underwent cataract with IOL implantation. And they apparently are also advocating that it is best that these children are not put in with an IOL, because I also, in my experience, I have explanted majority of these patients with the IOL, despite they being on an immunosuppression, very well-controlled inflammation prior to the cataract surgery. So I think we really have to hold back the IOL implantation, and probably in the later stage of their lives, if they are doing well and they are, adequately immunosuppressed, I think that's going to be the best time to put in the IOLs. So that is something I think we would all agree.
Another thing is that the patients who underwent cataract surgery with IOL implantation, we don't have that long-term study that after surgery what happened
Exactly.
to them. So very short, one year maximum the follow-up, and they say that they are doing well.
So I think that PGI Chandigarh study will add knowledge to us, because they are also saying that majority of them had to explant the IOLs. Yes. So moving on to our next talk by Dr. Mudit Tyagi, who is again a senior retina and a uvea consultant at LV Prasad Eye Institute, Hyderabad. And Dr. Mudit is also very passionate about endoscopic vitrectomy, and he would be sharing his experience of performing that in uveitis patients.
All right. So good afternoon, and first of all, let me thank Dr. Manisha ma'am for having me as a part of this IC and to AIOC Scientific Committee. And can I please have my slides? Yeah, so I'll be talking about the role of endoscopic vitrectomy in uveitis. Now we all know that in retinal surgeries, what we need for doing any surgery is a good clear media. In the absence of clear media, whether it is because of a corneal opacity or because of synechiae or because of cataract formation, our ability to do a vitrectomy or any retinal intervention becomes compromised because of the fact that now we can't visualize what's happening inside the eye. Now what endoscopy does is that because of the fact that it's got a inbuilt camera incorporated into it, it allows us for visualization of what's happening inside, obviating the problems caused by an opaque media. And I'll show you how they can actually be beneficial even in uveitic eyes. So if we look at it, the first ocular endoscope was developed way back in 1934, but the modern endoscopes that we use were developed in 1990, followed by 23 gauge systems in 2011. Now this is how an endoscopy system looks like. If you look over here, you have got a system over here which has got a built-in light source. It has got a camera which is built in with it, as a fiber optic cable which is fused into a 1923 or a 25 gauge micro probe. So it's got a light probe, an image acquisition fiber optic cable, and also a laser inbuilt into it. This is how it actually looks like. So it takes a bit of a learning curve, because now instead of looking into your microscope, you're looking at a screen in front of you, and that screen visualization takes slight learning. But once you have overcome that initial very minimal learning curve, you will be able to navigate most of your way. So this is what I mean. When you do a vitrectomy conventionally through conventional viewing systems, you've got a bird's eye view. So you're able to visualize from top what's happening over here. An endoscope, because of the fact that you're putting a light pipe inside, you only have an end-on view where you visualize whatever your endoscope is focusing upon. The good part is that even with an endoscope, we get a view of around 50 degrees in a fluid-filled eye and around 70 degrees in an air-filled globe. Now, how does it help in uveitic eyes? Now, the first point is that in a lot of these eyes, because of synechiae and ciliary body membranes, there may be a problem in the placement of our cannulas. And endoscopy helps us in assessing the position of the cannula, whether it's subretinal, occasionally subchoroidal, or what's happening in the subciliary areas. So you can visualize with the help of a probe what's happening to your cutters, what's happening to your infusion cannulas. You can visualize your ciliary bodies, so that's where its importance lies. And when you have to measure it from the center of an optical cylinder in eyes with keratoprosthesis, what you need to do is that you need to capture it, and you are able to now visualize what's happening over here in the ciliary body. These are eyes which have got already a migration of the pars plicatus and ciliary bodies anteriorly because of the membranes which are contracting, and putting just an infusion cannula otherwise can be disastrous. But an endoscopic visualization allows you to visualize your sclerotomy sites also very nicely. So like I said, what are the indications? Difficult to access sites like ciliary sulcus, sclerotomy sites, ciliary body, and the area behind iris, and that is where its importance lies in practice of uveitis. So coming on, what are the absolute indications or the role that endoscopy plays in a uveitic practice? And that can be both diagnostic as well as interventional. Now in terms of diagnostic, it helps us in visualizing and prognosticating as to what is happening inside eyes, where you have got a posterior segment pathology which you need to assess, but you are not able to do that because of an absence of a corneal opacification like what you will probably see in this eye. Or for that matter, this is an image from one of our publications, but these are the eyes with a failed graft, a keratoprosthesis. And while an ultrasound will just show you an attached retina, an endoscope helps us in assessing what's happening inside the eye in terms of the fact that this is an eye which has got an absolute glaucomatous optic atrophy with a pale disc and sclerosed vessels. So in few of our uveitic eyes with long-standing hypotony, also before going ahead with any subsequent intervention, what we did was we did a diagnostic endoscopy to assess the status of the optic disc and the macula before going ahead with any subsequent future interventions. So what an endoscopy allows in these cases is that it gives us a chance to prognosticate and understand what happens inside the eye. So like this was an eye with a total corneal opacity over here. And once you go inside the eye, what you find is a total pale disc with extensive scarring at the macula. So these are eyes which will probably not benefit with a future intervention. So you probably can then explain to your patient a poor adverse outcome which will be expected in these eyes, instead of going ahead with a intervention in terms of probably a transplant or any other future interventions in these eyes. Again, this was another eye with a corneal opacity, but if you compare it with the previous eye, now you see a healthy disc with a good neuroretinal rim, attached retina with a good macula, and these are eyes which probably will do good. This eye actually subsequently underwent a corneal transplant also. So that was the role of endoscopy in diagnosing or in prognosticating. But how can it help us in terms of interventional approaches? So in terms of intervention, what it does is it allows us a visualization of what's happening to ciliary bodies. And one of the most common causes of hypotony in these eyes are ciliary body membranes. So it allows us an assessment of these ciliary body membranes. It also allows us to remove some of these membranes. So this was an eye with extensive peripheral membranes, and what you can do is you can visualize this area and how you can use a cutter to shave off and remove these membranes, which with a conventional system would have been absolutely impossible to assess. So you can see the ciliary body and you can see some of these membranes which can be dissected over here. This was another eye with extensive ciliary body membranes, gross hypotony. This was the only seeing eye of this patient which had a vision of PL plus, the other eye was no PL. And when we went inside, we saw these extensive membranes all throughout the ciliary body. Also later on you will be able to visualize an IOL which can be appreciated later on, and along the IOL there were also membranes. So with the help of a forceps and scissor, what we were able to do in this eye was we were able to remove most of these membranes. Subsequently we did a vitrectomy and ended up putting oil inside the eye, and we were able to actually at the end of the surgery achieve at least an ambulatory vision. This patient from PL plus now has a vision of county fingers 2 meters in a silicone oil filled globe. But for a patient who had actually no vision, up to county finger 2 meters of a vision also can be a bit of a blessing. So what this approach allowed us was to go inside, assess the ciliary body membranes, try to remove as much of them as possible, which otherwise with a conventional system would have been more difficult. So in eyes with a persisting hypotony, Dr. Sangeet Mittal is here and he will probably be dealing with the topic of hypotony in uveitis. But what endoscopy now allows us is it allows us to intervene in these eyes and visualize what's happening. So that's how intervention can be done with the help of endoscope. I'll just show you one more thing. So this was another of our patients, and this patient had a chronic recurrent episode of inflammation which was coming again and again. And when we went ahead and checked what's happening in the angle of this patient, what we found to our surprise, and this is how an endoscope can also help us in visualizing and assessing the angle of the eye. And we found subsequently that this patient had an occult foreign body, which was initially not assessed and realized. So this patient had a glass foreign body, which was the cause for recurrent episodes of infection that were happening in this patient. And we were subsequently able to remove this. So that's how, I'll just show you one very small video again, which is not something which we commonly do, but which also highlights how sometimes endoscopy can be such a valuable tool. So this was a patient who had actually come to our cornea clinic with a toxic keratitis. This patient had a bee stinger injury. And because of the extensive corneal edema, our cornea colleagues were not able to remove the stinger. And what they did was this patient was having repeated episodes of corneal edema, toxic keratitis. And if you can see over here, so what we did was that instead of going ahead and trying to remove it superficially, because the stinger was embedded deep into the stroma. So I'll just show you what we did in this case for the interest of time. What we did was we went inside with an endoscope to visualize what is happening. And I think we've come to the previous slide. Just a second, please. Okay, so we were able to go inside, and subsequently what we found was, when we went and visualized the angle, was that we were able to visualize the stinger over here, which was deeply embedded. And then from the other side, we just made one more entry, got inside the eye. This is, we are deepening the angle with the help of a viscoelastic. And endoscope again beautifully allows us to visualize these angles. So the idea over here, the reason I'm showing is that sites which were earlier not accessible to us can now be visualized with the help of an endoscope. And subsequently we just went with the forceps, grasped the stinger subsequently and just brought it out. So this was the stinger which was causing all of this toxic keratitis, and we just could grasp it from the other side and bring it outside. So this was what. So in a nutshell, I will just sum it up by saying that endoscopy is an important modality that allows us to overcome challenges presented by anterior segment opacifications, allows for early VR interventions, and also management of ciliary body membranes and in tackling hypotony. Thank you so much.
Thank you, Mudit. You make it look very simple, though I know it's not all that simple to do an endoscopic vitrectomy. I have been really trying hard to learn it, but still struggling with it. I was just wondering that when we are trying to remove the ciliary membranes, majority of the time we actually land up doing a bimanual because they are in between the ciliary processes, and if you touch the ciliary process, they heavily bleed.
They heavily bleed.
So
what you can also do is, instead of trying to peel it off or trying to remove it en toto, the fact is that the reason they are causing a hypotony is because they are contracting, causing traction, and in the process creating dialysis. So while if you try to pull or remove all of them, it will cause bleeding, like what you said, ma'am. So you can do is, you can go with a cutter or with a scissor and then truncate them into multiple planes.
but with an endoscope, because you are having the camera in your light source only.
Yeah. So with one hand you have got your endoscope and light source, with the help of which you can visualize what's happening on the screen. With the other hand you go with a scissor and then
just
you
snip
go
it
and
off.
cut all of those under visualization.
Right.
So that way it helps. So you can truncate them easily.
Any questions from the audience? Thank you so much, Mudit. We'll move on to the next talk by Dr. Sangeet Mittal, dealing with hypotony in patients of uveitis, which is always the most disastrous complication of patients, especially with chronic uveitis. So Dr. Sangeet is a very well-known retina consultant at Thind Eye Hospital, Jalandhar, and it will be a delight to see his videos.
Thank you, Dr. Manisha, for giving me this talk, and good afternoon, everyone. So I'll be talking about surgical management of hypotony, and I've included videos also beyond uveitis also in patients like trauma, post-traumatic cases. But chronic hypotony, what you define is IOP less than 5 millimeters of mercury, which is prolonged, and it may be a result of glaucoma surgery, retinal detachment, choroidal detachment, ocular trauma, chronic PVR, chronic uveitis. They all cause chronic hypotony, and the consequences is like chronic pain you'll be having, then bad appearance of the eye, corneal edema. There could be hypertonic maculopathy, optic neuropathy, and even phthisis bulbi. And so you have to prevent this by increasing the IOP in some way. And most of the times we are able to do it conservatively by medical management or by giving intravitreal injections also. But sometimes you may need surgery to treat this condition. And various surgical options include the cryo adhesion, the repair of leaks, the choroidal drainage, vitrectomy with gas or silicone oil, epiciliary membrane removal, cyclodialysis, the cleft closure. There are also reports with the anterior encircling band, and there is a substance which is called foldable capsular vitreous body, which is not yet available in India and can be done. So this is one case. This was a video given to me by Dr. Vipin Vig, and this was a 16 years old girl who had a scleral coloboma, and there was a chronic hypotony in this case. And when he started to the vitrectomy, you see there is fluid leaking from one side. So lensectomy he did in this eye, and when he removed the lens, he found that there was a scleral defect over there from which whatever fluid was there was going out. And surgical options in this case include to close that defect by amniotic membrane, fibrin glue, gel foam, or sclerograft Tenon's patch. I myself have no experience of doing this, but if anybody has, can discuss this after this presentation. Next is choroidal drainage, and choroidal drainage which causes hypotony. If you drain the choroids, if you are able to do
controlled cannular drainage is a simple technique using a 26-gauge intravenous catheter for drainage of suprachoroidal or subretinal fluids. A 26-gauge intravenous catheter is taken and
this is my method, what I use to drain the choroidal and suprachoroidal or subretinal hemorrhage.
The tip of the catheter is then visualized and confirmed to be in the right space. Once confirmed, the plastic cannula is then advanced forward while the metallic trocar is withdrawn.
This is how you perform
The fluid
this.
is seen coming out of the cannula. The cannula is then connected to the extrusion pump of the vitrectomy machine so that the speed of drainage could be foot controlled. This is a case of post-trauma intraocular foreign body with choroidal detachment and hemorrhage. Due to massive choroidals, there was no space to perform proper vitrectomy. Controlled cannular drainage was done in fast mode to create space. The speed of drainage was reduced as the choroid became flat to prevent any tissue incarceration.
So this is how I do a choroidal drainage. Then you can, sometimes you need to do vitrectomy with silicone oil injection in these eyes to maintain the glow pressure. And in uveitis patients, one has to be careful, like the vitreous which is there is in gel form. And it's not like normal vitreous, and it appears as a gel form, and you have to take care about that. And triamcinolone in these cases may not stain posterior hyaloid because it's a sheet-like posterior hyaloid, which is not rough. And triamcinolone, mind it, does not stain, it just adsorbs on the surface of the vitreous, so it may not stain the posterior hyaloid. So you have to take care. And sometimes PVD is induced while you are doing the ILM peel. You realize that still there is the layer of posterior hyaloid over there. And so when we induce when we start the ILM peeling, we come to know of this layer, and then we can remove this. So in one case, this was a patient who had an hypertonic maculopathy. You see there is ILM folds near the macula. And he had a chronic hypotony, and in which we had gone in to treat her with vitrectomy and silicone oil injection. ILM peeling was done, and in this patient, silicone oil was injected. And this patient post-operatively had a good IOP buildup, and she maintained her eyesight after that. Then Dr. Mudit has shown endoscopic removal of cyclitic membranes, which can be done. And this was another patient of chronic uveitis with chronic hypotony, and she had all these membranes in the ciliary body area. And this case, forceps was used. This is a 23-gauge forceps which was used to peel off these membranes. But as Dr. Mudit and Dr. Manisha pointed out, there is a lot of risk of bleeding, and so you have to go very slow. You may desegment these membranes into various parts and then remove one by one. But endoscope is not available to all of us. We can do a under microscope visualization also. We can try to remove these membranes. The trick is that you decrease the IOP to a very low, like I am doing at around 5 millimeters of mercury here, and depress the ciliary body, and one by one you can remove all these membranes slowly. So this is another way you can use your microscopic view to remove these cyclitic membranes. Sorry. So this is a video by Dr. Manisha Agarwal. She how to repair the cyclodialysis cleft if it is present. And we have the video or audio also.
Injury to the right eye and vision of 624 N24 and a pressure of 2 millimeters of mercury. There was subluxated lens and hypotony maculopathy. There was 360-degree cyclodialysis cleft. We present the sewing machine technique to repair a cyclodialysis cleft. Lensectomy and vitrectomy was done, followed by intraop gonioscopy to confirm the extent of the cleft. A scleral flap was made and 10-0 proline suture was threaded into a 26-gauge needle and the needle was cut off. The needle with proline suture was passed through the cleft and a loop was taken out, which was kept in place with the help of a 30-gauge needle. This was repeated multiple times and multiple loops were taken out, which were kept in place with the help of the 30-gauge needle. The 30-gauge needle was extended to keep all the loops in place and the suture was finally pulled out and the tenoproline suture was then passed through all the loops. The 30-gauge needle was removed and the suture was tightened. The follow-up at 12 weeks showed a vision of 6.9 N6 with an intraocular pressure of 18 millimeters of mercury.
And she had repeated it on the other side also, just due to the paucity of time, can't show it. You can do anterior encircling bands in cases of cyclodialysis cleft, and there have been studies which showed that this is also sometimes helpful. A simple encircling band, just you have to make the anchoring tunnels just behind the aura or just behind the muscle insertions, and nothing much more in it. And this was a post-traumatic eye, and he had an improvement in intraocular pressure after that. This is the last
This
video.
is foldable capsular vitreous body.
This is due to courtesy
Air is
Dr.
being
Hussain Khan
injected to
from
inflate the
Pakistan.
foldable capsular vitreous body. After checking any leakage underwater, foldable capsular vitreous body is deflated and folded. Foldable capsular vitreous body is put into dedicated FCVB injector. Millimeter sclerotomy is done to inject the foldable capsular vitreous body into the vitreous cavity.
This is done in all gone cases, like to
Position
prevent
of
thysis bulbi in
FCVB
these
drain
eyes.
tube is secured with ethibond suture. The silicone oil is injected into the capsule via a drain valve.
Thank you.
Thank you so much for telling us of various techniques how to deal with hypotony. I'll just request the AV team to please put the video of Dr. Vishali Gupta. It's a recorded talk. Any questions for Dr. Sangeet? Thank you so much.
Lord Manisha, for inviting me to this very, I say with very challenging topics. I'm here to share with you the role of diagnostic vitrectomy in uveitis. Now, when we talk of doing vitrectomy in uveitis, it could simply be done to make the diagnosis, and that is if uveitis is undifferentiated, malignancy suspected, or non-response to therapy. Technically, it's not difficult to do vitrectomy. However, one has to take care that the samples are well respected, taking both diluted as well as undiluted sample, cassette fluid. There should be dedicated lab where the samples should be transferred without any delays in the cold chain, and the pathologist should exactly know what you are looking for. To give you an example of the importance of diagnostic vitrectomy, this 40-year-old lady was referred to me as a case of recalcitrant intermediate uveitis in her left eye. Now, when we examine the right eye, it did show some punched out lesions here and there, but nothing very significant. The left eye, however, had vitreitis, and it also had Ozodix implant in place. Now, autofluorescence showed those lesions to be hypofluorescent, and fluorescein showed these lesions became hyperfluorescent, but no leakage was seen. ICG was essentially normal. Left eye imaging did not show much results. So what next? We were not even sure whether it is infection or non-infection. I thought it was syphilis, but her repeated test for toxosyphilis was negative. Montius was positive, but this phenotype was not really suggestive of TB, so TB was not even, anti-TB was not started. Could it be non-infectious? Honestly, we did not know whether it was a kind of a multifocal choroiditis, and we thought maybe left eye had become infection due to the Ozitex. In short, it was undifferentiated uveitis. So this is the kind of the scenario when vitrectomy helped. So this is the left eye. When we saw it, the exudates, after clearing all the exudate and the Ozitex implant, we did see there were precipitates present on the surface of the retina, which were nicely seen on OCT as pre-retinal infiltrates. They were all aspirated and the cytology was sent out. Post-vitrectomy, when we did autofluorescence, it was similar as in the right eye, and the fluorescent did not contribute much. The report, however, was a kind of surprise to us. It showed a single large lymphoid cell with elevated IL-10, so there was a suspicion of lymphoma, but our cytopathologist was not very comfortable labeling it as lymphoma with a lot of certainty. So we thought it could simply be because there was Ozitex in place and steroids can delay the diagnosis. So we decided to repeat vitrectomy after 2 weeks of removal of Ozitex implant. And this time when we did vitrectomy, there were a lot of exudates which were taken. Few tips: a small gouge, there is no need to reduce the cut rate, especially with 27G. Samples should be obtained from apparently clear vitreous. Pre-retinal deposits, whenever seen, they should be sampled, and you should use the aspiration needle, as you would see in this video, to go close to the retina and take the aspirates. PVRL does not need any retinal or choroidal biopsy, just the aspirate of these. This is what I was talking about. This is really helpful to go close to the retina and aspirate them. Within 1 hour of this time, our pathologist said the whole sample has lots of cell, which is B-cell lymphoma, so the patient was treated, and this is how she responded. Not only diagnostic, the vitrectomy does have a therapeutic role because it removes all the cytokines. It removes type 2 collagen in the vitreous, which has arteritogenic as well as immunogenic properties. It removes the intraocular antibodies and organisms. And finally, when the aqueous that replaces the vitreous, and the aqueous actually has protective factors, so it is beneficial. This is how it works. There is a precortical vitreous pocket which has a very high concentration of the cytokines, and the amount of the steroids, immunosuppression you need to give is too much. When you do vitrectomy, you have removed all this, so the need for the subsequent immunosuppression goes down significantly. Many times, the vitrectomy is a kind of a combination of diagnosis and therapeutic benefit. For example, this young girl who had vascularized granuloma had received TB treatment in past and was not responding. She had developed complicated cataract, so we decided to go ahead with the cataract surgery, putting an implant, and then going in doing a 27G vitrectomy. And you can see this is under air to take the undiluted sample. It's important to put on the air so that you don't really have the globe hypotony, even though you are on a smaller gauge, and then we took the sample. And the sample interestingly showed rifampicin resistance, so that she was treated, and finally she could have a vision of 6/9. Many times the vitrectomy is because of the development of the retinal detachment, and many times this detachment comes in acute retinal necrosis, and these days we are seeing it appearing very early in the course of the disease. For example, this patient after 4 days on IV acyclovir developed the retinal detachment, which was confirmed. Now these are the patients where we actually have to, do the surgery very quickly, and it's important that when we are doing vitrectomy for retinal detachment with active retinitis lesion, you have to handle it very gently. I personally do not use triamcinolone for staining, especially in a scenario like this, because it's two active lesions right now present. The highest cut rate, for example, this one I'm using 20,000 cut rates, because you really know that the hyaloid is really adherent to the retina. So you don't want too much, pull, because the retina can come into the tissue. This was a very gentle nudge with the forceps to remove the hyaloid wherever it is too adherent, but you can't remove it en bloc. So you will have to go over the lesion, gently remove the hyaloid as much as you can, and many of them actually have shallow retinal detachments. So even the ILM peeling really helps. Now this point here was very adherent, so it was left, started from another point. You can see the sheen here, and I don't think I have the time to show the entire video, but you will have to work on it. ILM peeling is important to remove the ILM to prevent subsequent redetachment rates. Fortunately, they respond very well. They by and large do not redetach, and also the silicone oil somehow does not emulsify. So you have to use 5,000, because these are the eyes which need a very long-term tamponade, and you really don't have to remove that. Here I'm doing it, but if the retinotomy, and then a very gentle laser to the edges of the brick. You don't have to go very heavy on the, my 8 minutes are up. So you do not have to go very heavy on the laser. And this is how the patient behaves post-operatively. So I think my 8 minutes are gone, but many a times these patients may develop REG-RD, and they would have a lot of subretinal fibrosis, which needs to be tackled like any other retinal detachment. You just have to be very careful about the inflammation which might be seen in the post-operative period because of the uveitis, which needs to be concomitantly managed. So to conclude, I would just say that meticulous planning is the success to key. And with this, I would like to thank Manisha once again, and apologies once again. Thank you very much.
So thank you so much for participating in this IC, and we can now conclude the session, sir.
I wish we had more people to attend this meeting and could have good interactions, and both those mutual learning could have been possible.
But we got to learn from each other.
Yeah. Okay. Thank you very much, Manisha.
Thank you, sir. Thank you.
Yes, sir.